Welcome to episode 4 of the NHS Armed Forces Health Podcast, a series that aims to help you, the Armed Forces community, access the plethora of NHS services available. Through these episodes, we will look at different aspects of healthcare, from leaving service to finding a GP, taking care of physical and mental health, and provision for forces families. In today's episode, we're looking at physical health, whether that's the result of a medical discharge, chronic conditions, or simply keeping on top of things. For this, I am joined by Shehan Hettiaratchy, Chair of NHS England Clinical Reference Group for Armed Forces and NHS Surgeon, Teresa Griffiths, the former Commanding Officer of Defence Medical Rehabilitation Centre at Headley Court and Managing Director of the Drive Project, and Greg Stephenson, Mental Health Practitioner for Veterans High Intensity Service North, OP Courage. We like to begin each podcast with the same question to each person. Why did you get involved in the AFPPV and why are you here? I'm going to kick this off with Shehan, who everyone else calls H, so I'm going to do that as well. So over to you.
So I guess it goes back to I've been involved with the Army since I left school. I did a gap year, but I've been a reservist for about 20 years, serving with 144 Parachute Medical Squadron. I've deployed a couple of times to Afghanistan. And I think I'm a surgeon full time. So for me, it was kind of still being linked into those people we looked after on operational tours and tried to make sure, having kind of done the hard grafting, hard work while we're out overseas, to make sure those people and their families and their loved ones are still looked after and maintained in health once we're back in the UK.
And Teresa.
Hello, yes, I'm Teresa and I'm a veteran. I recently left the Royal Air Force after 27 years as a nurse. I'm a bit like H, I'm passionate about doing the best for our serving personnel and our veterans and the whole armed forces community and providing that care. I've deployed across the world to many conflicts. But latterly in my career, I was the military chief nurse at Birmingham and also the commanding officer of the Defence Medical Rehab Centre. And just prior to leaving, I was introduced to the AFPPV as the military serving rep.
Thank you. Great. And finally, Greg.
Yeah, I'm also a veteran. I've got lived experience of becoming physically disabled through service attributable injury, and I've since discharge become particularly passionate about mental and physical health. So that's why I'm here, just to share a little bit of my journey and my sort of vision of and experiences.
Brilliant. And we look forward to hearing about that. So H, I'm going to come to you first. What are the most common ongoing physical health needs veterans experience?
So it's a really good question, Alice. And one of the frustrations we have in the NHS system is, of course, we don't collect data on veterans prospectively. It's actually a hard question to answer. So what we can look at is our physical healthcare pathways we have set up for veterans, and we look at what comes through. The vast majority is musculoskeletal problems, so hips, knees, backs. But we also have people who've been involved in blast or had particular problems with potential brain injury. We also have hearing issues, and we see a wide range of things, all the way from problems with fertility to problems with heat illness. But the one thing that really kind of makes this group of people more difficult to treat on the NHS is they are quite complex, because as well as having those physical issues, they'll have chronic pain issues, and they'll often have mental health issues due to the context of how they became injured or suffered their physical health problems while serving. So it's a complex constellation, but I would say it's musculoskeletal combined with chronic pain and some mental health issues is the kind of most standard type of people we see.
Teresa, it's been said quite a bit on this podcast series that one of the major things leaving the military is to manage expectations in terms of the difference between the provision from the Defence Medical Services and the civilian NHS. Is this the case when it comes to physical injury? And if so, why?
Oh, I would really love to say that that is not true, but unfortunately, there is a gap, and the answer is yes. And the reasons for it are actually very complex. But the real reason for the gap is rooted in the existence of why we have a separate defence medical services. In military speak, we talk about military effectiveness as fighting power. And that's based on three components, which are the conceptual component, the physical component, and the moral component. And in very simple terms, the conceptual component's all about the ideas behind how to fight. The physical component is the means and the resources, which is obviously the equipment, the resources, and the people, which is the most important resource. And thirdly, the moral component, which is about the motivation for our soldiers, sailors, and airmen to fight. And the Defence Medical Services throughout history has been critical in supporting all of those components, but most importantly, the latter two. And as we've seen most recently in Afghanistan and in Iraq, it's been proven that if we can deliver the very highest level of care to our personnel on the battlefield, right the way through to rehabilitation, their motivation to fight and take greater risk on that battlefield is increased. So that supports the moral component. So it's critical that there is a really excellent medical support service. And the second reason that the Defence Medical Service exists is to maintain its people. It's a bit like maintaining a car. Our people are our most important resource. Without people, there is no armed services to deploy. So it's absolutely vital to ensure that they're maintained fit and ready to fight. And it would be completely inappropriate to have a serving force that is downgraded, wounded, sick, or unable to deploy when the government wants to actually, press the button and deploy that force. But the result is a gap between the two when the patients leave. And for the patients, that's a real gap. And of course, they don't care why that gap exists. They just see that there's a reduced level of care that they'd previously known. And for many of them, it's a perception that they feel that this reduced level of care is that society has actually forgotten them or that their service hasn't been valued.
Greg, I want to bring you in now. You've got direct experience of having been treated through the Defence Medical Services system and then out in the civilian world. So how was that transition for you?
Yeah, well, I was one of those very fortunate service personnel who had this fantastic care. The initial couple of years from point of injury on operations in Afghanistan was incredible. I was part of that well-oiled machine, and right from point of injury, surgery, through to getting prosthetic legs at Headley Court. It was an incredible pathway that not only looked after myself, but thought about my family, thought about the wider sort of context of injury, occupational therapy assessments, what am I going to do for work, all the things that were kind of buzzing around my head at that time, psychological therapies, and then the point came when I was medically discharged, and I think for me personally that's where I began to struggle a little bit. I was carrying an MSK issue. It was interesting to say that because I couldn't understand how I had this, I had these state-of-the-art prosthetic legs, but yet I had lower back pain that was preventing me from from engaging with them. And I was quite naive. I was newly disabled. I didn't understand what life envisaged with living with a physical disability. As daft as that sounds, I kind of thought about the obvious things, but my aspirations in work weren't feasible, in all honesty. At that time I was thinking, I might become a tree surgeon, I might do, I was thinking of all these weird and wonderful, careers which appealed to Greg pre-injury, but perhaps weren't quite as accessible with a disability. And I think that's a natural progression with anybody with a traumatic injury. You've got to now live with that. And also the family's got to get used to that. I wasn't Greg who, went off to Afghanistan. I was Greg now with a physical disability. So life was different. And as I transitioned, obviously there's a little bit more ownership on you to access service, which for me was a particular challenge. I didn't realise I was really poor at communication, but actually I was pretty awful. I was used to. I was only in the military for a short time, 6 years, so I don't feel I was institutionalized, but it was very familiar to me. I felt comfortable within the rank structure. I felt comfortable within, if somebody said something was going to get done, I knew it was going to get done. Whereas, sometimes, in the NHS, a big part of my role now within the Veterans High Intensity Service is to just ensure that communication streams are open, that the veterans being listened to, the family are being listened to, that the veterans communicating, physical injury, are they suffering with depression? Are they living with post-traumatic stress symptoms that have not been sort of exposed? And trying to look at the sort of fuller picture. And I think I developed that through my lived experience of perhaps thinking really obviously about the glamorous side of prosthetic legs and rehabilitation and running marathons, but actually forgetting the things that hold it together, the cement in rehabilitation, which is the sort of caring for yourself, the mental well-being, the really obvious things like the good communication, developing links with GPs, with physiotherapists, so that just using my example, the MSK issue doesn't become a huge issue where you might need surgery. You can deal with it at that stage where something can be done.
Teresa, what is the difference practically and I suppose emotionally between a medical discharge and leaving voluntarily? And then I'm just going to sort of add another question to this, and how or can it spill into people's prospects work-wise too?
Yes, so it's huge. The difference is huge, and it's all about control and choice. If you have a choice, you have control. If you don't have choice, you lose all of that control. And in the military, there's 3 ways you can leave. There's predetermined dates that we all know about, and we can plan against those. We can choose to leave for our own personal reasons, like I did recently. And then the third reason, as you've already discussed, and is the fact that people are medically discharged because they're deemed not fit enough to undertake that military role. And it goes back to what I was saying earlier. You can't have a military force full of people that are not fit. But at the end of the day, these are people, with needs, with families that need to be supported. So I think, irrespective of whether you're medically discharged or whether you leaving the military is still really, really tough. And that's because being in the military is really special. It's like being part of a unique family or a tribe. It has its own special language. You just have looks. You don't even have to actually speak. We have lived shared goals, experiences, and an understanding of what's needed. And of course, it's based on standing traditions, ethos, values, and history that we join for and we're really proud of. And there's this unique camaraderie and unspoken respect about being in it together and always having each other's back, even in the most darkest and dangerous times. So therefore, really, it should come as no surprise, I don't think, that if people suddenly find themselves being medically discharged, that this is going to be a massive impact on them because they didn't prepare for this. It wasn't their choice and they didn't plan. And in my experience, especially at Headley Court, what I found was that people are often not ready to leave. They feel personally a failure, that they actually haven't achieved career goals or roles or promotion. The military is all about a hierarchy of promotions. Being in the military is often, and has been for lots of people, a long time or a lifetime dream or ambition. So it's losing that dream. And what are they going to do? They can't possibly, what possibly can I do if I can't be in the Army or the Air Force or the Navy? And there is sometimes a fear of going back to something that some of our populations have escaped from. They left their families because it wasn't particularly a good experience. So they joined the Army, Air Force or Navy to get away from something. So the fear of actually having to go back to something that actually they escaped from is not good. And then there's that whole feeling of being dismissed, just the language that we use, medically discharged. We're looking at language across defence and society today. But that message in itself to our people, medically discharged, it almost implies you're no longer useful to us and that their service is wiped clean. So that emotional impact on top of having to transition into the civilian world without medical issue is huge, and often spills into individuals trying to seek employment outside, or just trying to find out what their new normal life looks like. And I think just before I finish, and I think we're going to talk about this later, when we're talking about physical health, there are two real distinct areas. There's those physical injuries as a result of combat trauma, and then there are those chronic disorders. But there's a real difference in those two, and how both the patients perceive themselves and how society perceives them.
Thank you. Can you just give us a bit more about that, just from your own personal opinion of those two differences? I think that's really useful for people who are listening, who perhaps have left because of, say, chronic pain, or because they've been injured in combat.
Yeah, there is a really big difference, and I use the experience at Headley Court. So in 2014, we left. The UK withdrew from Afghanistan, and there was an expectation that the activity at the Defence Medical Rehab Centre would go down, because why would there be a need for so many patients? This didn't happen. The numbers remained constant, but the patient profile changed. The trauma became less acute, but there was an actual increase in the number of chronic admissions. And many of these disorders were related to what H was talking about earlier on, the MSK, long-standing back issues, long-standing shoulder and knee problems. And what was really fascinating, but also very sad, was that most of this chronic group had associated invisible wounds and associated injuries that created this insidious spiral of almost like a spiral of doom. So most of these patients who've got chronic issues, as H will be able to explain more, have often got chronic pain. And if you have chronic pain, you're living with that the whole time. So they're on huge amounts of different painkillers that has an impact on their ability to do normal daily living activities. Many of them have mental health issues. They have low mood, they have depression, and many of them had PTSD as well, which was slightly differently related. They also struggled with low esteem, low confidence, and a lack of self-worth. And all of these compounded together to cause relationship issues. So many of them were looking at problems in their relationships, looking at divorce, relationships, problems with their children. They couldn't communicate with their families and extended families. And, a lot of the fathers didn't know how to communicate with their children. And of course, that runs into financial issues, potential employment concerns. So it's critical that we sort these issues out, because if we don't, then this particular group is much more vulnerable at potentially experiencing homelessness, going to prison, or worse, taking their own life. But for me, the worst thing was that this particular group did not feel that they were worthy, and they felt that they were fraudulent when compared to their colleagues with combat injury. And the truth is, and we haven't done the research for it, but the truth is that actually this group, there was a result of combat injury, but it took a much longer time. So it was probably a result of continuous deployments over many, many, many years, doing extraordinary things in the most austere of environments. And I was always absolutely passionate at Headley Court that these two groups should never be treated differently. Everyone is deserving of the same treatment, irrespective of how they gained that injury. And it's a real problem. And speaking a couple of weeks ago to some of the patients at Headley Court, that feeling still exists, even 10 years after Afghanistan and Iraq.
Thank you. So I think key points there. Transition can be challenging however you leave, and physical injuries can potentially affect every single part of your life if it's not managed effectively. But everyone is worthy of care regardless of how you're injured. And I think that's really interesting, that chronic pain is service related, but it might not manifest immediately. It might be further down the line. H, I just wondered if there was anything else that you'd like to add.
No, I mean, I think what Teresa describes is the complexity of some of the veterans we see. I mean, we have to put also in context because, majority of the armed force community who have healthcare issues have those resolved in a very positive way, often with just normal NHS resource. And we also should remember there's always a perception within service that the NHS is no good, and that sometimes can, sully their experience of transitioning. But the thing to remember for people who have been through service is the care they received in service was delivered by clinicians who work in the NHS, be they regular or reservist or otherwise. So, that level of quality exists in the NHS. And the trick we need to do is connect the armed forces community into those individuals who form that team when people are on ops, and make sure they maintain that care. Because the NHS is a big beast. It has 1 million patient contacts a day. And unfortunately, our armed forces community is a small part of that, but a very, very important part of it. So if we can basically connect up our armed forces community with those people within the NHS who have served or are serving or have military focus, then we can maintain that level of care that was delivered while people were in service. So that's what we've been trying to do. And I think the complexity that Teresa outlines is absolutely there. And for example, in our physical healthcare pathways, we make absolutely no distinction of whether this was combat related or not combat related. If you've got a healthcare issue that's as a consequence of your time served, whatever that is, then we'll pick it up. Now, actually, about 2/3 of those healthcare issues can be dealt with by normal NHS pathways because they're relatively straightforward. They're, someone's got a heart problem, that they can see their local cardiologist. Someone's got an ankle that got broken in training, but actually just needs a bit of fixing done by their local orthopedic surgeon. But some of them fall into a category that Teresa describes, where you've got a complexity of physical healthcare, mental health care, and chronic pain. And the problem historically has been that those people have bounced around the system because the NHS is not designed to look after those kind of patients. And it doesn't do it very well with civilian patients with equivalent. I'm a trauma surgeon, and my trauma patients often will end up in that kind of category. We don't have services within the NHS routinely to deal with them. So what we've been doing in the Armed Forces team over the last, particularly over the last 2 to 5 years, is developing a unique offering for that kind of high complexity level of patients. So to make sure they get their physical health care, their mental health care, and their pain issues dealt with in a holistic way alongside military charities. And I'm sure we'll come on to that later. So, I think Teresa's absolutely right. There is a very unique need in some of our patients who are transitioning through out of the military and their families. And I'm hoping what we can get across today is that the NHS is very much in the right place with the right people to step up to meet that challenge, and is meeting that challenge. And it's amazing to feel someone like Greg's actually involved in delivering the service. We've got the right people. We've got the people who understand the context and can deliver the effect, as Teresa explained. And it's really just trying to get that message out there that actually, that there are solutions to this. People do not need to suffer in silence or think there is no help. There is help, and there's the right help.
So don't suffer in silence. The NHS is the right place with the right people delivering the right service. I think that's
it's the NHS in collaboration with military charities. There's a really strong collaboration. So it's a strong relationship. As we saw during Afghanistan and Iraq, we delivered world-class healthcare because we have the NHS, Defence Medical Services, and the military charities absolutely lockstep together, focused around making sure that our serving men and women and their families are properly looked after.
So you've got that collaboration there. And then obviously this is sort of underpinned, or the framework sits within the Armed Forces Covenant, which states that no member of the Armed Forces, present or past, or their family members experience disadvantage or inequality because of their military service. So H, just sticking with you, what does this mean in practical terms to this community group?
I think the right way to talk about this is that we want the best care for our armed forces community as we would any other NHS patient. So all we're doing is saying every NHS patient should get the best care possible, including the armed forces community. And then we can say, well, look, the armed forces community is different. As we've heard, you've heard from Greg, we've heard from Teresa, there's different healthcare needs. And the NHS every day of the week is creating separate pathways. I don't like to call them pathways. I'm told not to call them pathways, but separate offerings for people who have different healthcare needs. You might have brittle asthma as a child, and you need to have a particular healthcare need. You might have some really complex, mental health problem. You'll have different healthcare needs. You have different offering. So all we're saying is the armed forces community in that model have different healthcare needs, which if are going to be met effectively, have to have a different offering that is bespoke to what they require. So what we have developed in the Armed Forces team is that bespoke offering, which is based around what our Armed Forces community and their families require. And the reason that works in a way that trying to push priority doesn't work is if you don't have the right offering that meets what the needs that people have, it doesn't matter if you're first of the queue or the end of the queue. When you get to the front of the queue, you still get the right healthcare. So that's why priority, I think, just doesn't work. It's pointless. What is pointful and what is delivering effect is making sure what we have created within the NHS with our armed forces charity partners is what our veterans and their families and the armed forces community that are serving reservists need. And I think that's what we're in the process of doing. I think we're building the fact we've got people like Nikki involved, we've got people like Greg involved. I've had lots of conversation with Teresa about this. I think we're now very much a long way down the road in developing that. So I think we are on the way to develop, I think, the best healthcare offering for armed forces community in the world. It'd be better than the US, better than Australia, better than Canada. And I think we should be giving people in the armed forces community the confidence to know that it is coming and they can ask for it and it is available.
Greg, can I bring you in here? You've obviously used the system. You're now working within the NHS for Up Courage. What would you like to see improve? And is there anything veterans can do to help themselves?
Yeah, it's a really good question, and one I'm quite passionate about. I'm really excited by some of the things that H is saying. I think that's clear and obvious that the consistency for me needed to just improve slightly. There was some fantastic work, and it's really obvious that the NHS can do fantastic work. There is a bit of a bashing within the veteran community, and I think that comes from fear of discharge. Fearful of the unknown, fearful of being mollycoddled a little bit by the armed forces, because it's a small cohort. With a your direct access route. Every camp has a medical officer that you can kind of get hold of on that day, but. Yes, I think there's a lot of reasons why the veterans are fearful of the NHS, but that shouldn't reflect on the NHS, because there are fantastic services, and I'm a benefactor of many fantastic services. Surgeries and prosthetic MS. Help with the MSK issues with my back. To the point where now I can work a full-time job and run around after the kids. And that they weren't options that were on the table when I was in that. Cycle that Teresa mentioned, where I was highly medicated, I was immobile, I was unable to use my prosthetic legs, I was propelling in my wheelchair, gingerly, isolated, not communicating with people, not taking the social opportunities that I was being presented with. And it's a slippery slope. But that sounds really obvious, but it only takes one of those well-being spokes to sort of drop out of your wheel to really feel that impact. And the knock-on effect of that is unfortunately veterans not being able to access service for a magnitude of reasons, and the effect that has on families, friends. It really can. I've been there at the moments where things aren't looking great. If you are physically incapable because you like my position where I had a bad back preventing me. It's painful every time I moved. Where do you start? And you begin to have different ambitions, because you may be, me personally, I was becoming quite depressed, I was gaining weight, I was turning to alcohol, I was smoking again, I was doing all these things that I didn't do at Headley Court. And guess what? At Headley Court I was on a trajectory to smash it and really get on with it. And then I had this fall off point where things weren't going great, and and reflecting on that, I thought, well, actually, come on, Greg, what can you bring to the party here? You've got these fantastic services available to you. Yes, they might be a little bit slower. There might be frustrations in communication, and you might need to just, speak up and have the confidence to say, this is what I need to and this is what I would like to achieve. And once I understood that, and once I was shown how to do that, by fantastic organisations like Blesma, were pivotal in my care, in saying, giving me a little bit of a kick up the backside and saying, "Come on, Greg, you're a big boy now. You need to speak to the GP. You need to. Who's aware that this situation is unfolding?" Because I was relying on my family, on my wife, quite a bit, to sort of speak to her about my mental health, and like, I need to get an appointment. What do I need to do? And then actually, do you know what, Greg? The ownership is on you to. And that would be what I would share from my experience with other veterans. What can you bring to the party? Is it that stopping smoking might help? The way you're recovering. Is it that you're using alcohol as a crutch and a coping mechanism? Yes, there's some wonderful attributes to alcohol. It might make you more social. It might help you sleep. But actually, we all know the negatives. Well, and I felt that. I felt more depressed. I felt lethargic, didn't want to get out of bed, and they're the really clear, obvious things that veterans can bring to physical sort of disability and physical MSK issues. Because I'm just fearful that if we don't sort of embrace rehabilitation with the fullest of attitudes, and I'm not the fun police, and I would hate to see the veteran community, you lose some of those rough edges, because that's what makes us fantastic. But what we need to do is actually think about it in a bit of a professional way, almost like an athlete. That's what I sort of try to relate to some of the service users I come across. Say, think of yourself as an athlete right now. What can you do that's going to bring the best out of you? Is it that, do you know what, I'm not going to drink every night of the week? Is it that I'm going to cut down on the cigarettes? Is it that I'm going to try and maintain a decent body weight? These simple things, be more physically active, look after my mental well-being, spend time with the kids, read them a story, all these things that actually help increase self-esteem, help you sleep better, better nutrition. And guess what, that cycle, it begins to sort of turn the other way. It gives you the self-esteem and confidence to, get into work, to volunteer opportunities, to be a better father, to be a better husband, to be a better mother, to be a better partner, whatever it is that sort of just enables you to engage life. So I think that's my message. The message is, without being too hard on yourself, just think about the quick wins and the small things you can bring to the party to enable your rehabilitation.
Greg, that's absolutely fantastic. Some really amazing messages there. Don't be fearful of the NHS. Approach this like an athlete. There are fantastic services. And, hearing your story, you were doing so well while you're still serving in your rehab. And then you left and you fell off the edge a bit. But look at you now. Take ownership. Let people know you've served. But ultimately, and I love this, what can you bring to the party? And it's stopping alcohol, potentially smoking. I think that's such a great line for all of us, or for everyone to sort of think about. How can you take ownership on your own health? H, I see you nodding there. Was there anything that you wanted to add to that?
I think Greg's point about consistency is very important. Even though I kind of, paint a kind of a very positive picture for NHS, we know we've got a lot of work to do to make sure that the provision for armed forces community is far more consistent, far more available, and far more understood both within and without the NHS. So even though, I think we're on the right journey, we've got a long way to go. And Greg's absolutely right. A more consistent approach so any veteran, any member of the armed forces community and their families can access this kind of care at the right level wherever they are in the country.
Fantastic. And Teresa?
Yeah, and just to add to that, I think there's a requirement to better educate our leaving personnel, especially those that are medically discharged. The resettlement process for leaving personnel is absolutely brilliant. I mean, it is just an incredible process. And I think that the MOD need to perhaps create a separate bespoke resettlement process that goes along the normal resettlement, but actually better supports them, because a lot of the opportunities are not taken up by those serving personnel because they're not in the right mental health space. They haven't got the motivation to go, oh, what job shall I do? Oh, what should I go and do this? All they want to do is just exist, for the rest of that day, or, work out how they're going to, pay their salary to get, food on the table to feed their families. So I think there is a space there for the MOD to perhaps look at that specific group and perhaps try and create a bespoke resettlement for those medically discharged. And then you can create that education that H and Greg have both talked about in their discussions. And you can perhaps improve their communication skills. You can provide them an understanding that they're not going to be dropped, that actually the quality of care is no different. It's just different. But actually, there's different ways that you've got to access it. And you've got to be much more vocal and take control, like Greg has said, in actually accessing that. So I think there's a space there that we can all do better.
So for the service user, take control, be proactive. And I suppose for the family members, you can support them with that. And we've got a separate family episode at the end of this series as well. Thank you. So H, can you tell us about the Veterans Trauma Network and what it does?
Yeah, so Veterans Trauma Network basically came out of this concept that, as I said, we've got military-focused clinicians within the NHS throughout the system. And they're desperate to look after armed force community. They really are. They've worn uniform or they're wearing uniform, and they want to look after the members of the armed force community, many of whom they looked after previously. So we know they exist within the NHS, and what we've done is basically link them up. So we've now got these people identified. And so what does that mean is if a veteran comes in with a service-related healthcare issue, doesn't matter, how it was suffered. It might be a training accident, might be combat related, could have been just twisting your ankle, going around the block, something like that. They can be referred in via their GP to the network. We do a process where we look at what the physical healthcare problem is, what needs they want, what needs they have from a medical perspective. But in addition, we're partnered with Defence Medical Welfare Service, so one of our military charity partners, who provide a veteran support worker to that individual veteran and their family to identify is there anything else that can be provided. Because, the NHS is good at doing the medicine. It doesn't do all the other stuff, which is really important. So looking after the families, looking after the kind of social issues, who's going to pay the rent, are there any other issues that need to be dealt with that could be really contributing to making this individual and their family's life better. So they will do an unpacking with the veteran and their family about what the issues are. We'll then look at that referral and look at the problems that individuals got with a multidisciplinary team. So we have a link up between our physical healthcare pathway, the Veterans Trauma Network, Op Courage, our Veterans Mental Health and Wellbeing Service, our military charities, such as Blesma have been a really important part because they're an awesome organisation. DNWS, Help for Heroes, supporting wounded veterans, walking with the wounded, they're all clustered around this individual. And basically what we do is unpackage the problem. And so some of these cases that come through just need very simple provision. They've just got a physical healthcare problem. But as we've talked about already, a lot of them don't. A lot of them are very complex problems that we have to unpackage. And the reason these individuals, the ones we're seeing now as we've matured, have been going around the system for 3 or 4 years is because not one person owns the solution. So me as a surgeon, I can solve 10% of a problem. But if the Op Courage mental health person can do 10% and someone else does 10%, then if you have 10 of us together, we have a 100% solution for that veteran. So I think the real strength of the physical healthcare pathway is, yes, we'll sort out the physical healthcare bit, but the real strength, I think, is that augmentation we have by bringing together physical and mental health, bringing together our chronic pain service, bringing together the military charities, so we generate a proper holistic solution for that individual and their loved ones. So, I mean, it's been a work in progress for about 4 or 5 years. We've, in the last year, we've put some resource into it from the Armed Forces team in terms of program manager and a case coordinator. And that's meant that we've got more and more referrals coming through, which is fantastic because we know there's lots of unmet need out there. One thing I will say, just final thing I should add is, because we're NHS England, this is talking about England. However, Wales have set a similar system up 2 years ago, VTM Wales, and we had a discussion with Scotland. And Scotland are setting up an equivalent. And I've got a discussion with Northern Ireland, which obviously is a challenging area. But we can, I think one of the good things about the different nations is everyone wants to do better than the other ones. So when we pitched Scotland, they said, well, we'll do it in Scotland, except we'll do it better than England. I said, brilliant. If you do it better than us, fantastic. So hopefully we'll get this across the whole of the UK.
Great. Teresa, Is there a difference between the outcomes of people with a direct combat-related injury and people who develop longer-term chronic ailments?
To my knowledge, there hasn't actually been any, the outcomes actually haven't been measured between these two groups, but I think that differentiation is too specific. And I think what we need to do more, we need to better understand what the healthcare needs of our populations are, whether that's in the serving population or the veteran community. And if we have a better understanding of what the health needs are of the serving population, then that is going to manifest itself into the consequences of the veteran community. So I think rather than differentiate between the chronic and the combat, it needs to be what are all the health needs, but also it's looking at what are the health needs of our female population, and what are the health needs, of our LGBT and our Commonwealth, our populations. And if we better understand those, then I think we'll be in a better place to identify what's actually needed. And we are doing much better, but the two organisations are still siloed. And I feel, this is my personal impression, is that the sort of veteran, the medical care almost feels like a baton, that when you're serving, if you're serving, it's the responsibility of the MOD. And when you're out, it's the responsibility of the NHS. And H articulated perfectly earlier on, we're just a different group, of the NHS. There are lots of different groups out there. We're just a different group, and we're actually very, very small. So we shouldn't be seen as this baton of handing over, because when you hand over responsibility, often that other organisation then abdicates or thinks, well, that's my job done, and I'm off. So I don't think that it should be seen as that. And I think it needs to start with better understanding what those needs are and working on those, and sort of getting away from that combat versus chronic.
So for the service user, the armed forces community, stop differentiating. It doesn't matter how you got injured or what your injury is, just go and ask for help.
So I was going to say, from our perspective, from the NHS perspective, it makes no odds how you ended up in front of us as healthcare needs. So it doesn't matter to us how you ended up with your healthcare need. We're here to solve your healthcare need. And just one thing with Teresa points absolutely bang on is the ultimate irony is with a healthcare problem in service, seeing a particular specialist in a certain hospital, military specialist in a certain hospital, you can then transition out as a veteran. You might end up seeing the same specialist by the NHS. So, it's not like we've got two separate systems. We've got the same basically provision, just accessing it through different pathways.
Greg, have you got any thoughts on this? And is this something that you've observed as well?
I think it's something I experience, in my current role as well. I can't hide my disability. I try to, but me walking in with two prosthetic limbs sometimes, I have been challenged, by people, by veterans who say, well, listen, mate, I've got an MSK issue, or I might have a bad back, and I feel a bit daft talking to an amputee. And I sort of reflect on that and say, listen, just like I said before, the thing that held me back the most was an MSK issue. Pain does not care if you're an amputee because of the most heroic, war effort ever, or if you've slipped on ice, walking to the local shop. Pain is a beautiful thing in some ways, because it's so consistent. It doesn't care. It'll get you, and it'll hold you down if you let it. So, my message back is that consistent message of, listen, if you are in pain, or if you have a condition that is preventing you from living, a full life or achieving your goals, then let's do something about it. And I like to think that, both sides, we shouldn't see them as separate, but we can inspire each other. The cohort who were injured in Afghanistan, for example, got first class gold standard care. But it's what we can learn from that can help other people. Just today I saw an email come through from one of the studies saying, combat injured veterans are more likely to have, heart conditions and strokes later on in life. So we're at this really cool stage. Actually, we're learning so much from, these the advanced study and some of the great things that have been going on, in the background. of actually what can we learn from this cohort who did have a lot of resource and were, we're prima donnas at the end of the day. We were spoiled a little bit, but it's what we can learn from that, and it's what we can we inspire anybody with who requires rehabilitation and support. And I think we are getting very good at that, and we've learned a lot over these last 10-15 years. We have learned a hell of a lot, and it's just about now utilising that lesson across the board.
Fantastic. And what a great message. Pain doesn't care. It will get you if you let it. So that is something. Go and get that help and don't worry about how you've got that pain. And yeah, that's wonderful. H, is there any further advice you would like to give to the armed forces community in terms of accessing healthcare?
I'd just say, actually, we are working really hard to try and get the message out. The education piece that Teresa mentioned, to make sure everyone understands the needs of the armed forces community. But it's a long haul. There are, as I said, 1 million patient contacts a day in the NHS. GPs are really under the pump at the moment with lots of other pressures, not just COVID, but loads of different things. So they may not know what they should be doing, to be honest. And we see this all the time. And I would say just remain persistent. If we can give you the right information, that self-advocacy that Greg was talking about, unfortunately, is going to be required, at least in the next few years. We're definitely changing, turning the dial on this one, so it will become easier. And then when a veteran or any member of the armed forces community or their families go in and see a bit of a health service and say, actually, this is related to time served, then there should be a response. Okay, well, I know what to do with this, but it's going to take us a few years to get there. So in the meantime, they could then go into whoever they see in the healthcare system, armed, as it were, with the information, with the knowledge, so they can advocate for themselves. We're working behind the scenes to make sure that hopefully the future state is they won't have to fight to get this, that it'll be obvious, and that people encourage them into this pathway. And as I say, we're trying to make it as simple as possible, literally an email. And some of our contacts are just literally an email from a family member saying, I'm worried about this is what we've got, then we can pick it up. So I think it's a work in progress, but I think we need to work together on this, both from the armed forces community and those who are there charged with providing care. We'll end up in a really good place.
And I suppose that collaboration piece, it's not just the NHS, military charities, but also the service user, the armed forces community is part of that team. The NHS is under pressure, they might not know. So pulling on Greg's point, be that athlete, be prepared, be armed with knowledge, and let them know about time served.
One thing I will say, the NHS is under pressure, but do not underestimate how important this is to the NHS. We've rolled out Op Courage, the Veterans Mental Health and Wellbeing Service. We've expanded our physical healthcare pathway. We've expanded it in Wales, expanded it in Scotland. So do not think, for the armed forces community, this is not important. We are still really accelerating this work.
Teresa, over to you now. What advice would you give someone with a physical issue in negotiating the system and making sure they stay on top of their treatment?
They absolutely have to own their disorder or their disease or whatever they've got, and understand the why behind those associated issues and invisible wounds, and have the courage to make those invisible wounds visible. So do what Greg says and tell people, okay, I've got this, but actually I'm also struggling with A, B, C, D, E, and F. Don't keep them invisible. And in thinking, and you need to think out of the box in how you're going to treat them. You're out of the military now. Think of, find like-minded communities and find sources of, activities that potentially may support you and help in, supporting those issues that you're struggling with. The second one is, and this is whilst you're serving, and then we're not very good at this, and this does relate to sort of chronic issues. If you have a sort of small or less acute MSK issue, as you're going along the service, don't wait for it to become really big. Deal with it. If you've got an issue, don't go, oh gosh, I really should go and see a doctor, but I really want to go on that exercise. So it's in our DNA to go, I'm just going to ignore that because that's what I joined up for, and ignore it and then come back. And I think that you really need to tackle that problem there and then. Of course, some disorders are going to progress and become chronic, but the way that we're set up in the Defence Medical Services is that you move around a lot of locations. So you'll be in one area for 3 years and have a pathway of treatment, and then you'll go to move to another location, and treatment can often be restarted again. So it's about owning it and having that voice. And the third one is that we need to educate and empower our patients to challenge clinicians and the system when it's necessary. And we need to teach them how to use their patient voice properly so that they can really influence care. And this is where the AFPPV comes in providing them an opportunity to actually, explain what their issue is, or give the issue to that group, for the group to then, support them and going forward. And it's beholden on all of us to actually listen to our patients, because one of my raison d'etres, and everyone gets really bored when they hear me talking, is that we exist in the medical world to look after our patients. And as clinicians and medical people, we can sometimes forget the patients. And I always say, if we put the patient central to our decision making, we actually can't go wrong. So it's really important to educate that patient voice and actually make sure that we're actually listening to it.
That was great. Be visible, be proactive. And I love this. Everyone was smiling when you said this, Teresa. Tackle the issue when it's small and don't wait. Challenge the system and use your patient voice. Use the AFPPV, who're doing some fantastic work on the Armed Forces community behalf. And so finally, to Greg, what advice would you give someone to use their patient voice?
Teresa summed that up so well. It was, but for me, the point I made right back at the start, communication. Communicate. 'Cause I think it's a weakness, across quite a few veterans, I dare say, that we do withhold information for a whole host of reasons, just because of the crack-on sort of attitude that we develop, and we want to see peers and family members getting support, but perhaps not ourselves. So please communicate. And also, please don't discount yourself. We've seen examples across the veteran community, where people are discounting themselves from services. And it's a broad spectrum now, the veteran community, and rightly so. And we're proud of that. We want to support all veterans. So ultimately, if you've served at least one day, and you need support, please reach out and grasp that support. Just like H said, fire the email across, or if you're more comfortable with somebody doing that, be it contacting a third sector charity, there's plenty out there. Find a way of making that contact that that you find comfortable, and reach out. And please don't discount yourself. Just get the message out there, and keep banging the drum until the support is there.
Thank you to all my guests today, H, Teresa and Greg, and to you for listening. In episode 5, we'll be looking at mental health, the various pathways available, how to get help, and what to do if you are struggling. We hope you will join us. Goodbye.